you again, everybody, for your time. Again, my name is Matthew Menendez with White Plume. I'm going to be walking you through the webinar this afternoon. This webinar is designed for pediatric practices, and we're going to be talking about how to make the transition to ICD-10 successful for both your providers and your revenue cycle. Quickly, just what I hope to accomplish in the next 45-50 minutes. I'm going to start with some general background information on ICD-10. I assume everybody knows what it is and why we're working on ICD-10, but we're going to take a bit of a different approach with this background information. One of the things that you hear oftentimes is that the United States is one of the last countries to move forward with ICD-10, and that is true, but there are some things that make our transition a bit more difficult than a lot of other countries who've moved forward with ICD-10. So we're going to look at some of the unique challenges that practices here in the United States face. There are a lot of practices that are behind in their preparation. They're going to be using the next few months to try to catch up before October 1st. So I'm going to share with you some of the mistakes we see other pediatric practices make in the hopes that you may be able to avoid making some of those same mistakes. But there is also a lot of misinformation, a lot of bad information out in the marketplace about ICD-10. So I do want to share that with you to try to dispel some of those myths. So ICD-10 doesn't seem quite so scary or quite so impossible so that you can be successful in your transition. We're going to move quickly into talking about how to understand the impact specifically for your practice so that you can share that information with your providers, with your staff. You can focus on which areas will be easy, which areas will be difficult so that you can successfully transition to ICD-10. And there are a couple of themes that you'll hear throughout our time today. The first is talking about physician productivity. We have to focus on that first. If your doctors aren't taking care of your patients, if your doctors aren't generating revenue for the practice, nobody else is doing that. We've got to keep your doctors focused on patient care, not turn them into coders. But at the same time, we have to balance that with the real need that says you do need to get paid for those claims. You do need to make sure that you can turn those encounters into cash and that you've got the necessary coding detail to do that. So you'll hear me talk about physician productivity. You'll hear me talk about the revenue cycle. Another theme that you'll hear throughout our time today is the difference between ICD-10 compliance and ICD-10 productivity. A lot of people mistake ICD-10 as a compliance-only event. They look at it similar to a pass-fail course in college. You have to do it, you want to pass, but you don't need to do any more than barely passing. And that's simply not true. There will be some practices who are very well prepared for ICD-10. There will be others that struggle. There will be practices who do the bare minimum and whose cash flow is in a difficult place. There will be others who make the necessary workflow adjustments so that their providers and their cash flow are as productive as possible. So you'll hear that theme throughout our time today. As I said before, I'll make sure to leave plenty of time for questions and answers. Use the questions panel within the GoToWebinar control panel to ask any of those, and I'll make sure that I try to answer as many of those as I can. So what makes ICD-10 so difficult? What makes it hard in the United States? The first thing is it's a one-day conversion. I'm sure everybody is familiar with this, October 1st, 2015. It's a Thursday. That's the ICD-10 conversion date. Now, that's not dissimilar from what a lot of other countries have done. A lot of people have a one-day conversion to ICD-10. What makes ours different is the fact that this date has changed many times. The expectation has not been clearly communicated by the government. It's been changed twice by CMS, and then most recently last spring by Congress. That uncertainty makes it very difficult to be prepared. It's a lot like the boy who cried wolf. Everybody remembers that story, right? At the end, when the wolf comes, who pays the price? It's not the boy. He certainly lost his credibility. But who pays the ultimate price are the sheep and the owners of the sheep. It will be the exact same way when ICD-10 arrives for the practices who are unprepared. It won't be the government who suffers. It will be those practices and their providers and their employees and ultimately their patients. You have to make sure that you're prepared. Now, I realize for a lot of administrators or billing managers or project managers who are responsible for ICD-10, that can be an uphill battle because you may have other people in your organization, you may have doctors in your practice who expect that ICD-10 will get delayed again. And that seems very, very unlikely. But it's an uphill battle that a lot of people fight. We're going to talk about how to push back against that. What else makes ICD-10 difficult? Well, it's a big change for physicians. Now, it was a big change for physicians in Canada and Australia, New Zealand and France, other places who've already moved forward with ICD-10. Sure. But in those countries, the physicians are basically government employees, not small business owners like they are here in the United States. And our physicians, under the fee-for-service world, they can't slow down and see fewer patients. They're paid based on their productivity. They're paid based on their volume. They can't slow down and see fewer patients for an unfunded mandate like ICD-10. The other part that makes this particularly challenging, again, for the project managers and administrators, is the doctors aren't interested in ICD-10 either. They don't want to spend the time to learn about it. And if you can't teach them about ICD-10, how are they going to be productive in an ICD-10 world? How do you do that? We'll talk about some strategies to do that as well, but it's an uphill battle. It's an uphill battle, and it's a unique challenge here in the United States. But the last one is what I think really separates ICD-10 from a lot of other projects, a lot of other initiatives we've had in healthcare. We've had a lot of change over the last 6 or 7 years. Think about it. We've had e-prescribing and PQRS and meaningful use, just a parade of government programs. But all of those programs were optional. All of them would be phased in. All of them would offer incentive payments for Medicare and Medicaid reimbursement. They might have an eventual penalty down the road. None of those things are true of ICD-10. ICD-10 is mandatory, not optional. There's no incentive plan. It's all stick, no carrot. 100% of your cash flow is at risk overnight. And it's not just the government payers. All carriers are required to move to ICD-10. So there is much more at stake than any of the other programs we've managed over the past 5 to 6 years. And more practices are further behind than they should be. Because it's not just about getting an ICD-10 code on a claim out the door. It's about getting it coded correctly and that you've jumped through the appropriate hoops for each of your carriers to get the claim paid correctly. ICD-10 is going to be difficult, and a lot of practices are behind and need to spend time over the summer to catch up. Let me point out a few of the pitfalls we see other practices make, so maybe you can avoid these in your ICD-10 planning. The first one is the wrong assumption that ICD-10 is just a coding project. You know, some of you may be in this position where the practice basically says, you know, we've got a coder, we've got a billing team. They need to be educated on ICD-10. They need to go to classes. They need to go to boot camps. But it's really not going to impact anybody else in the organization. Now, that's a half-truth because, yes, it is a very big change for billers and coders, but they're not the only people who are going to be impacted in the organization. That's a part of a successful strategy, but it's not a complete strategy. Another similar mistake we see people make is the assumption that it's just an IT upgrade. You know, every ICD-10 checklist I've ever seen always has a component that says check with all of your external vendors. Make sure they're going to be ready. Make sure that you're on the right version of your clearinghouse or practice management system or EHR. And all of those are good recommendations. But it doesn't go far enough. That's only aimed at compliance, right? We've all worked with enough software programs to know it's about more than being on the right version. You need to understand how that version is going to work. What type of workflow changes will you have to make? Are those acceptable to your staff? Are those acceptable to your providers? Will they actually do it? How long will it take them? You need to dig deeper. If you ask a vendor, will they be ready for ICD-10? The answer is always yes. When you start to dig deeper and say, show me how it works with my examples, sometimes you get a different answer. So you have to view ICD-10 as a strategic initiative because of what's at stake. And that means you need to have your management team on board. You need to have your doctors on board. They don't have to be in on every single meeting, but they do need to understand what the risks are and what the strategies you have in place to mitigate those risks. And the two big risks, if you hear nothing else, what I would say focus on is how to protect against a decrease in physician productivity. How do I keep my doctors focused on taking care of patients instead of administrative coding tasks? And at the same time, how do I make sure we keep our revenue cycle efficiency in place? And when I say revenue cycle efficiency, what I mean is think about the head count that you have today. Think about the labor hours that are spent to collect your cash flow. Because if you have to spend more time to collect the same amount of dollars, or if you have to spend the same amount of time to collect fewer dollars, or if it takes longer to bring in that cash flow, those are bad outcomes. You have to protect against that. If we try to put a few numbers to this, I'll share with you a study that was done by the advisory board. They looked at Canada's transition to ICD-10 and tried to come up with what were the costs, what were the productivity losses, the long-term costs of ICD-10. And look what they put front and center, a decrease in physician productivity, 10 to 20%. Yeah, that is entirely unacceptable for a busy pediatric practice. Most practices do not have the margins to support that. If you want to get underneath those numbers and understand what was happening, these groups had coders that were coding from the doctor's documentation, and they would have to go back and ask the doctor, be more specific about this. Tell me more about the type of wound. Tell me more about the anatomical location. Tell me more about the etiology. Tell me about the diagnosis stage. That back and forth communication cost the coders time and cost the doctors time. And for the providers, it was on average 45 to 90 minutes per provider per day. Most doctors, even if you cut that number in half, most doctors don't have that time available in their schedule. Are they going to see fewer patients? Are they going to be further behind in their schedule? You know, those are not good outcomes. Are they going to stay late and answer these questions at the end of the day rather than spending time with their own families? I don't think it's fair to ask our doctors to do that. So we have to protect against that. We're going to spend a lot of our time talking about that. But you've got to look at the other pieces of it as well. Let's talk about coder productivity, and let's talk about that rework productivity. For coder productivity, if you don't have coders, replace that with biller productivity. You'll see a significant decline in the first year, but they will gain some of that back as they get up the learning curve. But they won't ever get back to current levels of productivity. And the reason why, it's not their fault. ICD-10 is just more complicated than ICD-9. So we want to make sure that you protect against that so you don't have to hire additional staff, so they don't have to work overtime. Can we put processes in place? Can you put tools in place to make them more efficient? And then look at the rework productivity over there on the far right. You see that decline is from additional denials, inquiries, adjustments coming back from the payers. That seems to match up with the early end-to-end testing results that we've seen so far this year from Medicare, is denial rates are doubling and tripling as a result of ICD-10. So if your denial rate today is 2 to 3%, it could be anywhere from 4 to 9% in ICD-10. Now that's not a catastrophic increase, but it is significant. And you can't control the payers. You can only control your own people, your own process, and you need to make sure you're prepared to handle the changes that are coming. That's why I share this information with you. I want to take a good, clean look about what ICD-10 is and what it is not, so you can be prepared to be successful. So let's talk for just a minute about what ICD-10 is not, because there are some people who spread bad information about ICD-10. But let me dispel a few myths. One of the things that you hear a lot of people talk about are how many new codes are in the code set. And they talk about 69,000 codes in ICD-10 compared to only 16,000 in ICD-9. And again, that's true. But it's only a half-truth. Because what they don't tell you is most practices, most pediatric practices, use less than 2% of the entire code set. Nobody uses all 16,000 ICD-9 codes. And you won't use all 69,000 ICD-10 codes either. So we always recommend focusing on the codes that you do use. Let's pay attention to those and see how those are going to convert to ICD-10. Because a lot of attention gets paid to codes that you're never going to use. And probably one of the most infamous codes that nobody ever uses are some of the crazy new codes in ICD-10 that people like to make fun of. Right? This is probably the most infamous one. I'm sure everybody has seen something like this before. And, you know, and it does make for funny mental images. The flaming water skis encounter, V91.07XD. Right? I'm sure everybody has heard of that before. What most people have not heard about is that is actually a code that exists in ICD-9 already. It already exists. You can go look it up in the ICD-9 code book. It's E837.4. You never use it today. And your patients aren't changing with ICD-10. Right? You're going to see the same type of patients. You're going to see the same type of problems. You never see this today in ICD-9. You won't use this code in ICD-10 either. Most of the crazy codes that people like to make fun of, you know, and I see this on blogs all the time. I see it on Twitter. You know, I see it in marketing pieces. There's a code for that in ICD-10, right? A lot of people like to poke fun of these codes, and they are funny, but most of them already exist in ICD-9. They're E-codes, what are called external cause codes in ICD-9. And CMS has already come out and said, if you're not using these external cause codes today, there is no new national requirement for you to use those in ICD-10 either. So let's not worry about those. Let's focus on the codes that you do use. This serves as a distraction for a lot of practices. It makes ICD-10 seem impossible, and it keeps their focus off of where it should be, which are the codes that they use today, some of which are the silent killers. They're going to be very dangerous, and I'm talking about unspecified codes. Unspecified codes exist in ICD-9, and they continue to exist in ICD-10. It's a dirty little secret. Most practices frequently use unspecified codes. Whether they use it as a catch-all, or they use it to save space on their fee ticket, or they're using it to make the documentation easier for the doctor in the EHR. A lot of people use unspecified codes, and there's really no harm, no foul in ICD-9, right? They're payable diagnosis codes in ICD-9, but that's going to change in ICD-10. There are two risks to using unspecified codes in ICD-10. The first one is a short-term risk that you'll probably see from some of your payers starting in the fourth quarter of this year or the first quarter of 2016, and that is that the claim won't get paid. If you use certain unspecified codes, the claim may not get paid in ICD-10. And let's zoom out and I'll explain why. Think about, why are the payers advocating for the adoption of ICD-10? Why have the payers lobbied Congress to move forward with ICD-10? Why have they spent millions of dollars rewriting their systems to handle ICD-10? They want the more detailed diagnosis code. They want the more granular information on the patient's problems so that they can use that to ultimately drive down the cost of health care. That's why the government payers want it. That's why the private payers want it. And if the provider community does not give that to them, they are going to deny the claim. That's the risk in the short term of using those unspecified ICD-10 codes. Now, what's the long-term risk? Well, the long-term risk is everybody knows we're moving away from fee-for-service. We're moving towards alternate payment models, towards pay for performance, pay for quality, pay for outcomes. And in that world, it is all about expected outcome as it compares to actual outcome, meaning how sick are your patients and how good are your outcomes. You need the more specific ICD-10 codes to show the severity of your patient's conditions, to maximize your reimbursement, to maintain your reimbursement in an outcomes-based payment model. So those unspecified codes are okay today, but you need to be careful about those in ICD-10, both in the short term and in the long term. Okay, so I recommend focusing on the codes that you use today, and let me show you how to do that. We'll get real practical for a minute. We've done this for all of our clients. Take a look at the codes that they use today in ICD-9. And then we see how they convert into ICD-10. You'll see most practices use somewhere in the ballpark of 200 to 300 codes today in ICD-9. When you take that and convert that into ICD-10, you'll see everybody has a significant increase in ICD-10. More than 4 times the number of diagnosis codes for most pediatric practices than what they use today. You know, thank goodness you're not orthopedics, right? But you may have some orthopedic type diagnoses, some musculoskeletal diagnoses for sprains and strains, or maybe even fractures. Those will be some of the more difficult codes to convert to ICD-10 for your practice. Now, we want to go a step further because not all codes are converted equally. Some are easier than others. So we put them into 3 different risk categories: low risk, moderate risk, and high risk. I'll show you examples of each, but let me explain first. The low risk are those ICD-9 codes that have one match in ICD-10. One code in ICD-9, one code in ICD-10. Unfortunately, for most pediatric practices, that's less than half of what you see on a day-in, day-out basis. It's somewhere 40 to 45% for most pediatric practices. The others fit into that moderate risk or high risk category. And that means the moderate risk category are those ICD-9 codes that have between 2 and 10 choices in ICD-10. The high risk are those that have 11 or more. So let me show you, I'll give you kind of a more detailed example of what that looks like. Here's a sample ICD-10 conversion analysis. You see up at the top the red numbers. Those are the summary numbers that match up with what you saw on the last screen. But if you look down below it, it has the line-by-line detail. So where it shows you a code like 786.2 for a cough in ICD-9, it has one matching code in ICD-10, and the new code is R05. The new description is cough. Right? Those are really easy. We love those. Let's look at the next example for impacted cerumen, 380.4, one code in ICD-9, 4 choices in ICD-10, left ear, right ear, bilateral. Now, if you look at that first code, you'll see there's a valid ICD-10 code for an unspecified ear. You can look it up in the code book. It's there. It exists. The problem is, think with me for a minute, what happens when you put that on a claim? What happens when you send that to Blue Cross Blue Shield and you're billing them for the extraction of that cerumen, but you didn't know which ear it was in? Are they going to pay that? Are they going to pay that 100%? It's a valid code, but you may not want to use it. Right? Let's look at the next one. This one's even more complicated. It's one of the high risks. It has 20 ICD-10 codes for that one ICD-9 code. Right, otitis externa. You've got to be more specific about the type of infection. You've got to be more specific about which ear. Now, I show this to you for several reasons. Number one, it's a great place to start. If you haven't done ICD-10 conversion analysis like this, I would strongly recommend that to you. For people who attend one of our webinars, we do that as a free service. If you send us your ICD-9 codes, we will send you back this ICD-10 conversion analysis. It typically takes us a couple of days to get that back to you. But if you'll let me know in the questions panel that you'd like that, I'll make sure we have somebody follow up with you so that we can get that done for you. But number two is I think it's helpful information to share with your staff, to share with your providers, because it relieves some of the anxiety. It lets everybody relax a little bit about ICD-10. It makes it seem doable. You start to look through this detail, and you see that the new concepts, the new codes, the new descriptions in ICD-10 are not foreign. They're familiar. You don't see anything about being struck by a turtle or walking into a lamppost or flaming water skis anywhere in this report. They're all things that you're already familiar with. So it relieves some of the anxiety about ICD-10. But the last thing that it does is I think it points clearly to the fact that it is a significant increase in the number of codes, and we can't just expect to use the status quo like we are today. Right? That's the problem. That's the real concern. And if you're a numbers person, if you're a data person, I think this is a great way to look at it. If you're more of a visual learner, let me show it to you this way. I'm going to pick on the American Academy of Family Practice for a second because they put this on their website. It's a paper super bill that they recommend their members use. And it looks like every super bill that I've ever seen. CPT codes on the front, diagnosis codes on the back. Pretty simple. What really caught my attention was they also had an ICD-10 version. And the ICD-10 version looked like this. The front side stayed the same. No changes to CPT codes on October 1st. But the back side, well, the back side looked like this. It was 8 pages long. And I use this as an example to point out that this may be an ICD-10 compliant solution, but it's not productive. Can you imagine from a workflow perspective having an 8-page super bill floating around your office? Now, I realize not all of you may use a paper charge ticket, but I want to use it as an example to think about the difference between productivity and compliance. That won't work. Even though it has all the valid, necessary, 1,200 ICD-10 codes that you may need, that's not an effective solution for your providers. So how do you think about that? What do you do? Well, you're trying to address a problem like this. You need to think about what the problems are and why it works so well today. Because an 8-page super bill won't work, and a jumbo super bill won't work either. Very clearly, there's not enough room on an 8.5 by 11-inch piece of paper to include all the diagnosis codes you'll need in ICD-10. But some of you may not do it that way. Some of you may have doctors that are writing in a description. Coders are coding from a note. Maybe they're doing it through their EHR. It's not just the codes that matter. It's not just the codes that change. The descriptions are changing. The concepts are changing. Right? That's what's different. And if you're not more specific in the description that they're writing in, they're still writing in just OE for otitis externa, you're going to be right back to that Canada problem of 45 to 90 minutes per doctor per day answering the follow-up coding questions. That's what we want to avoid. And so you have to ask yourself, what makes this work so well today? Whatever process you're talking about, what makes that work so well today? We did a survey last year and found 54% of practices are using a paper charge ticket. Even if they have an EHR, you still have 54% of practices that are using a paper charge ticket. And I think it's because it's so fast and so easy for the provider, and it gives the billing team all the data that they need to get the claim paid. So we want to use that muscle memory. That's why the doctor can fill it out with their eyes closed, because they know where the codes are on the page. Use that to your advantage when you're trying to solve an issue like this. I'll show you, kind of walk through 3 different scenarios of what we've seen pediatric practices do to handle this. The first one, I see this more in the hospital world than I do in a private practice, but it's hire certified coders. Now, where this breaks down for most private practices is it's too expensive. It's too expensive today, and they can't make it work in ICD-9. It certainly won't work in ICD-10 because coders are getting more expensive, not less, and they're getting less productive, not more. It's kind of a double whammy from an ROI perspective. But I did want to mention it because I do see some people trying to do that. The other 2 options I think are I see many more practices doing successfully. And the first one, this one sounds easy for me to say. It may be harder for some of you to do, but is to get your doctors to use EHR correctly. Right? And when you talk to a practice that's not doing that, it's not because their doctors are technology averse or they just enjoy being non-compliant. No, it's usually they're worried about their productivity. They're worried about their time and how long it takes for them to do it that way. It takes them too many clicks. The challenge for administrators, the challenge for project managers on this is that gets worse, not better in ICD-10. That's the concern. That's the challenge. And it's the way that this is why you need to check. If you're planning on going down this road, you need to make sure you understand how your vendor plans to handle this. Many vendors are handling this through a code search process, and that sounds like a great idea, right? Search, it's easy. It's like Google, right? You put all 69,000 codes in a database, you type what you're looking for, and you pick it out, right? That works when you're searching on Google for apple pie or for directions, right? It does not work the same when you're searching for a diagnosis code. And let me explain why. If you search for something like diabetes and you get 50 search results, right? When you search for something like that on Google, 99% of the time the answer that you're looking for is the first one. But that's not how it works in code search. You have to, it's like an SAT test. You have to read through all of the available choices to choose the one that's most accurate for that particular patient encounter. And if you're not careful, many times the first search result, the one most likely to be chosen by the provider, is an unspecified code because it's sorted in code order. Remember, if we go back to our ICD-10 conversion analysis, if you started to search for impacted cerumen, look what the first choice would be. That unspecified ear, negative consequences downstream for the revenue cycle. That's why it's important to understand not just that it works, but how it works. Now, I'm certainly biased, but I like the third option best, an electronic superbill, because it can be designed in a way to protect the doctor's muscle memory. It can look just like the paper superbill. That makes it fast to train the doctor, and it makes it fast for the doctor to use. Both of those are very good at making ICD-10 a non-event for the provider. But at the same time, it can be customized to make sure that the billing team gets the data that they need to get the claim paid correctly and completely the very first time. Let me show you what I mean. I'm going to bring up, this is Capture. It's an electronic superbill. We custom design each one to look like your paper ticket. So if you put E&M codes on the left and labs on the right on your paper ticket, we want to do the same thing with the electronic superbill. So let me do one encounter in ICD-9 because sometimes a picture is worth 1,000 words, and then we'll turn around and do that exact same encounter, this time in ICD-10. All right, so if I did a level 3 office visit, we did a lab panel, we did a cerumen removal, right? Click, click, click on the CPT codes, and then I flip over to the back side, and I see my diagnosis codes, right? In ICD-9, relatively easy. Let's go ahead and select that diagnosis for cough. Right there's impacted cerumen, and where's that otitis externa? There it is. Right, 1, 2, 3, pretty fast, pretty simple for me. Now what I'm going to do is that exact same encounter. I'll do them side by side so that you can see the difference. And I'm going to do it this time in ICD-10. I want you to pretend I'm one of your providers. I haven't come to any of your ICD-10 training classes. I'm going to show up. It's Thursday morning, October the 1st, and I'm going to try to figure this out. Okay, front side looks the same. No changes here. So far, so good, right? Now let's flip over and look at the back side. Is it going to be 8 pages long? You know, what does it look like? Nope, it's exactly the same. It looks just like it did the day before. That's great. So far, so good. No change. All right, now let's click on cough. Watch this. When I click on cough, you're going to see it highlights in green rather than in yellow. That's just a visual cue to the user to know that something's different, right? Let you know that something's different, and it said it's an ICD-10 code. It converted it automatically for me. It's got the new ICD-10 code. It's got the new description, R05, cough, in there for me. Again, I love those. You don't have to do anything different on those. Unfortunately, everything's not so simple. So let's look at a more complex example, like impacted cerumen. When I click on that, you'll see it can't convert that for me automatically. So it gives me a pop-up. And it shows me my choices for left ear, right ear, both ears. Now you'll see it does give you that choice for unspecified ear, right? Now this is where coding is part art and part science. There are places where reasonable people can disagree. But a lot of our clients have decided they don't want to show their doctor the choice for unspecified ear. They don't want to give them that choice. So what they do is there's a configuration option that says, you know what, I don't want to see any of those unspecified laterality choices. So they only have the choice for left, right, or bilateral, because we've never run into a patient that has a third ear. If it's in both ears, one extra click closes the pop-up window for me automatically, puts in the new ICD-10 code, puts in the new ICD-10 description, and I'm done. All right, well, let's look at the really hard one with 20 choices. Otitis externa. When I click on that, it doesn't list all of those out in a big, long list that I have to read through. It's organized it for me, where it has the laterality, again, on that horizontal axis, but it has the type of infection there on the vertical axis. So it makes it easy for me to, rather than reading through 20 different descriptions that are very similar to one another, I can very quickly go, oh, it's cellulitis of the left ear. One extra click closes the pop-up window for me automatically. Again, puts in the new code, puts in the new description, and I'm done. That makes ICD-10 a non-event for my provider. You know, one more quick thing. If you do have any providers that are still dictating or documenting manually, a lot of our clients will use this summary tab, just a summary of everything that's selected on the encounter form, but they use it as a reminder for the provider, for their dictation, for their documentation about who they saw and what they did. Some of them even have staff print that out for them at the end of the day if they're not going to do that on the fly. And what that does, it serves as a reminder of where I need to be more specific in my documentation for ICD-10. You know, most practices are documenting fairly well for most of their encounters, but there may be a couple of places where they need a reminder. This allows you to provide that to your doctors on the fly, rather than having to require them to spend time learning the new code set over the summer. Again, trying to make that easy for your providers to capture the right data that you need to get the claim paid in a timely manner, get it paid correctly the first time. Okay? So I spent a lot of time talking about the provider, about how they're going to do that. How do we protect their productivity? Let me spend the last 5 minutes or so talking about the revenue cycle, and then I'll answer as many of your questions as I can. When we think about the revenue cycle, it is a big change for our providers, but it's also a big change for our revenue cycle employees. And for revenue cycle, it's not just a one-day change, right? You know, you think about them and what they deal with. They're going to be dealing with the after effects of ICD-10. They're going to be dealing with the claims that get denied, the changes that the payers want, right? We think about it from a very high level. Today in our fee-for-service world, you get paid for CPT codes. But you have to have the diagnosis code that make it medically necessary. That's true in ICD-9. That's true in ICD-10. If only it were that simple, right? You still have all the hoops and hurdles that you have to jump through for the payers. You know, Blue Cross wants it this way. Aetna wants it that way, right? They don't all do that the same way. You deal with this today in ICD-9. We've dealt with this in ICD-9 for the past 30 years. You probably have billers and coders in your office who know a lot of the ins and outs of that cat and mouse game in their head because they've done it for years. The problem is that head knowledge, the rules of that cat and mouse game, go out the door on October 1st. The rules of the game will change. And again, not each payer will handle that the same way. Remember, the insurance companies have never done ICD-10 before either. That means they're going to be learning as they go. They're going to be making adjustments as they go. And that means in the months and quarters following ICD-10, that game is going to change very, very quickly for all of your payers. And the volume of change is going to be much higher than anything we've seen in our careers. So you have to ask yourself, okay, how are we going to manage that? What types of tools, what types of processes do we need? Who in my office is responsible for that? And maybe the scarier question is, what happens if we don't do a good job of that? The point here is for the revenue cycle, ICD-10 will be a marathon, not a sprint. And if you're going to run a marathon in October, you want to start getting in shape for that now, right? You want to start getting in shape for that now. And what that means is get your denial rate as low as possible. Make sure that you have a good process in place to respond to changes that come from the payers as quickly as possible. You know, we recommend a process called closed-loop denial prevention. We recommend this to all of our clients. Anybody can do this. We obviously have software that makes this easier for our clients. You know, it's like having a trainer that works with you to work out. Some people need that extra tool. But it basically says you can't rid the world of denied claims. You can't impact the payers, right? They're going to deny claims. They're going to issue new policies. That's a fact of life. But when you see one of those, you go through this process. You go back to the beginning and you figure out what went wrong. Figure out how to build in a new rule. That way, the next time that exact same scenario occurs, whether it's in 2 hours or 2 weeks or 2 months, that rule is going to fire the exact same way every single time for every single employee. It doesn't matter if it's your most senior certified coder or your newest billing clerk. They both have access to the same actionable information that tells them what's wrong and what to do to correct it at the right point in the revenue cycle. You know, that's a closed-loop denial prevention process. That's what may make the difference between ICD-10 compliance and ICD-10 productivity. And that's what I want to finish with. This is the last slide, and then I'll try to answer as many questions as I can. I want you to think about what you want your practice to look like in October. What do you want your practice to look like in November of this year? What's the goal? Is the goal to be able to submit claims that have ICD-10 codes on them? Or is the goal to have anticipated the types of workflow changes that you'll need to make so that you've optimized your workflow for ICD-10, both for your providers and for your billing team? You know, are my doctors going to be staying late to answer coding questions? Or have we taken the steps necessary to protect their time, to protect their productivity? Are they going to be able to remain focused on taking care of patients? Or are they going to be answering a lot of coding questions? Because think about your patients. They're not thinking about ICD-10 at all. They're going to expect, and their parents will continue to expect, the same type of high-quality care that you provide today. And we've got to have our doctors focus on taking care of patients. They didn't go to medical school to be a coder. And what about your billing team? Are they going to be working nights and weekends to get claims out the door? Or are we going to make sure that they get the right code the first time? Are they going to have to manage the back and forth process with the doctor? Or are we going to get them the data that they need to do their job? Are they going to have the types of tools that they need to respond to the changes that come from the payers? Or am I going to have to hire additional employees to do that, or outsource part of my follow-up work to do that? And that's the challenge of ICD-10. There's no additional revenue associated with ICD-10. It's supposed to be revenue neutral. And so if you have to do more work, if you have to hire additional employees, if you have to outsource some of that work, you'll be less profitable than you were before. And the concern is that a lot of practices won't realize this on the front end. They won't see it until they're unable to pay quarterly bonuses to their doctors at Christmas time. Or they look at their year-end financials and wonder why it wasn't as good as it was last year. And they'd be right to blame some of that on the government, absolutely. But it doesn't have to be that way. You can get out ahead of this. You can plan to be successful in ICD-10 and to make sure that you're productive. If you can automate some of the processes that you're doing manually today, you may even be able to be more profitable than you are today. You know, ICD-10 will be difficult, but it doesn't have to be impossible. I know I've covered a lot of information today and I've moved through that quickly, but I hope that this has been helpful for you, that you might have gained some ideas, some thoughts, some strategies to make the transition to ICD-10 successful for your practice and successful for your provider.